Dear student, in this I will try to give you a brief outline on pulmonary function test. The learning objective of this video is that after the end of this session you will be able to understand the meaning of FEV1, FVC, FEV1 FVC ratio and the flow volume loop. You will be able to use these values during diagnostic evaluations, and you will understand how FEV1 can be used to grade severity of disease. Now, what are the indications of PFT? To diagnose the symptomatic diseases, for example, chronic dyspnea, cough, unexplained hypoxemia, hypercapnia, especially in smokers, occupational exposures. Asymptomatic patients with high risk, for example, having some occupational hazards. Prognosis of known disease, to diagnose severity of the disease and monitoring the response to treatment. Contraindications of PFT: no absolute contraindications. It is a very safe method. Although presence of an acute illness or symptoms like nausea, vomiting that might interfere with the test performance may be a contraindications. Hemoptysis, current pneumothorax, or unstable cardiovascular status because it may aggravate the angina, or recent myocardial infarction or pulmonary embolism. Thoracic, abdominal or cerebral aneurysm because risk of rupture may be there. Recent thoracoabdominal surgery, recent ophthalmological surgery, recent sinus or middle ear surgery or infections can be contraindications. Now, what PFT tells about it? It tells about the airway patency so that we can diagnose the obstructive lung disease. It tells about the parenchyma, alveoli or interstitium, so we can diagnose the restrictive lung disease. And it also tells about the pulmonary vasculature. Now, symptomatic patients to be suspected about either having these three diseases: obstructive disease, restrictive lung disease, or the vascular disease. There are different types of PFT, but especially in this video, we will cover the spirometry, which involves the flow volume loop. So this is a spirometric report we usually do in our department. Here you can see it is a case of patient, that is a Kamirujaman Mondol. The age 21 years, male, height is 163 centimeter, weight is 57 kg and non-smoker. When a patient comes to do a pulmonary function test, we have to put some parameters to the software. For example, the age of the subject, weight, height, smoking history, and also in which posture we are performing it. So when we put this data, so according to this age, height and all these data, the software gives a predictive value for that specific patient. Here we can see that in 21-year-old, in this patient with this height and weight, the predicted value of FVC is 3.37, predicted value of FEV1 is 2.95, and FEV1 FVC, we can see the predicted value is 87.61 is the ratio, should be the ratio. And we can see that the performance of the subject is very well. So his FVC predicted value was 3.37 and he has done 3.59. So 107% is the predicted value. Similarly, 98% is the predicted value he has reached, and FEV1 FVC ratio, it is also 92%. So we can say that the person is having a normal lung function test. Now, in the slide, we can see in this slide, there are two curves. The upper curve is the flow volume loop and the lower curve is the FVC maneuver loop. Now we will discuss about these two curves. One is the FVC maneuver. The FVC maneuver curve, here along the x-axis you can see we have plotted the time in seconds, and along the y-axis we represents the lung volumes in liters. Okay. So what are the parameters we see? What are the key features? First is the steep initial phase, because this is the effort independent phase. So when a person performs a PFT, so we ask the subject to inhale first, take the deep breath, then exhale. So when the person is exhale forcefully, so there will be steep rise. The forced expiration, so there will be steep rise, and the slope of this curve it will determine the PEFR or peak expiratory flow rate, which is the highest airflow achieved during the maneuver. Okay, and the flow PEFR means delta V by delta time, that is a steeper slope indicates faster air expulsion. Second is the gradual plateau. When the PEFR is reached, we can see that there will be a gradual plateau. The curve starts to level off as the airflow slows. This phase is influenced by airway resistance and dynamic airway compression. So this is an effort independent phase. It does not depend upon the effort, and it happens automatically due to airway resistance and dynamic airway compression. This volume approaches FVC, which is to the total amount of air exhaled. We can see here. Now another parameter we can see here is the FEV1. It is a volume exhaled in the first second, 1 stand for 1 second of the maneuver, which is marked by the dashed horizontal line, and it is very crucial in diagnosing the lung diseases like especially the obstructive lung disease. In obstructive lung disease, FEV1 will be significantly reduced due to airflow narrowing. And when the final plateau it has been reached, that means the residual volume has been reached. So the clinical interpretation will be the rapid rise of PEFR followed by a normal smooth descent of plateau is a normal thing. But if the curve has a slower rise, concave shape and prolonged exhalation, so there is chance of obstructive lung diseases. And if the total volume is reduced but the shape remains normal, then it indicates the restrictive lung disease. Now come to the flow volume loop. So in the previous curve, we have plotted time along the x-axis and volume along the y-axis. But in this curve, we will plot along the x-axis the lung volume in liter, whereas in the y-axis, we will plot the flow, that is liter per minute. Now what are the phases of this curve? First is the expiration phase. So as I have told you, when the person do the PFT, so first they exhale. So the upper curve, it indicates the exhalation or expiration. So it begins with the total lung capacity. Obviously patient has taken a deep breath forcefully, so it will start with the total lung capacity. So when there will be forceful exhalation, rapid increase in the expiratory flow, it will reach the PFR or peak expiratory flow rate value. The flow then it will declines as the lung volume decreases until it will reach the residual volume. So it will start with the TLC and it will end with the residual volume. So now come to the lower curve, which indicates the inspiration. So it will start with the residual volume where airflow is negative. Now the flow gradually increases as the lungs are filled with the air and forming a symmetric but slightly concave shape. Now what are the key parameters? We can see the FVC here, that is the total volume from full inspiration to full expiration, that is the gap between the TLC to our residual volume. We can also see the PEFR or peak expiratory flow rate. What is the clinical importance? In case of obstructive lung disease, we can see here in mild obstruction and also in the severe obstruction, there will be a coving pattern. Okay, and in case of severe obstruction, the FVC is also reduced. The gap between TLC and RV, that part is also reduced, but that remains normal in case of mild obstruction. In case of restrictive lung disease, we can see that the shape of the curve is normal. Okay, there is no coving, but there will be a narrowed loop. The gap between the TLC and RV, it has been reduced. That means the FVC is reduced. Now, these are the major values we get in the spirometry. And what about the interpretation? So if the FEV1 FVC ratio is less, so we can suspect the obstruction. If the total lung capacity is low, then the restriction. And there are other parameters by which we can detect the both mixed type of lung diseases. That will coming in the next slide. Now, if we are suspecting that the patient is having the obstructive lung disease, so if FEV1 in case of FEV1 it is normal or decreased. FEV1 FVC ratio, if it is less than 70%, that means the person is suffering from obstructive lung disease. But in case of restrictive lung disease, As the FEV1 and FVC proportionately decreased, so there will be no change in the ratio. So ratio will either be normal or it may be increased. Now, this is a spirometer machine, and what we do, how we prepare the patient, we first explain the purpose of the test and demonstrate the procedure to the patient. We record the patient's age, height and gender. We note the bronchodilator when it was last used. The patient sits comfortably, usually we perform it in the sitting posture, and loose the tight clothing and empty the bladder. The breathe in until the lungs are full. Now we will ask the subject to hold the breath and seal the lips tightly around a clean mouthpiece. Then blast the air out as forcefully and as fast as possible. And continue the blowing until the lungs feel empty. Usually for 6 seconds the air should be blown out. Now watch the patient during the blow to assure the lips are sealed around the mouthpiece, because if the lips are not sealed around the mouthpiece, there will be air leakage. That will give an erroneous result. Then we will check to determine if an adequate trace has been achieved. Repeat the procedure at least twice more until 3 readings and 5% of each other less was obtained. So this is a test we can see that we do in our lab. So here you got one patient, the nose are blocked by the nose clip and the patient is attached to the spirometry. So here what we do actually, so here we ask the subject, you can see the subject is exhaling forcefully and there a balloon is blowing out here, and we are getting the upward curve, that is inspiration, and after that when it finishes around the 6 seconds, we ask the subject to inhale, and the subject will inhale and we will get the inspiratory curve. So this is a better view where you can see that in the screen when the subject is exhaling first, so we are getting the expiratory curve first, then we are getting the inspiratory curve. Now this is the curve pattern, and here we can see that the predictive value is given and how the person is performed. So 141% of the predicted value in case of FVC. In case of FEV1 it is 110% of predictive value, and FEV1 FVC ratio it is 79% of the predictive value. So we know that if FEV1 FVC ratio is more than 70% of the normal value, then it is okay. So the patient is having a normal pulmonary function test. Now if we suspect the obstruction, the severity of obstruction, it is categorized by Gold's criteria. If FEV1 more than 80%, it is Gold stage 1. If it is between 50%, it is less than equal to 50% and more than equal to 80%, then it is the stage 2. If FEV1 is less than 50%, but it is more than equal to 30%, then it is the stage 3, and if it is less than 30%, it is Gold stage 4. Now come to the interpretation. So first we will assess the FEV1 FVC. If the FEV1 FVC is low, then we will go for the FVC. So first parameter will measure the FEV1 FVC, then the third parameter is the FVC, and the second parameter is the FVC, and the third parameter is the total lung capacity. Okay. So if FEV1 FVC is less, then we will see whether FVC is less or not. If FVC is normal, then it is it is due to the obstructive lung disease. Okay. So now if the FVC is also low, then we will assess the total lung capacity. If the total lung capacity is normal or high, then it is obstructive lung disease. If it is low, then there may be mixture of obstruction and restriction. So now come to the other part of this algorithm, that is FEV1 FVC ratio is normal or high. Now you assess the FVC, second parameter FVC. So FEV1 FVC ratio is first, second is FVC, third is total lung capacity or TLC. Now if we see that FEV1 FVC is normal and FVC is also normal, so then we can say that it is either normal lung mechanics. Whether it is normal we'll say later. But if the FEV1 FVC is normal or high, but the FVC is less, then we will look for the TLC. If TLC is also low, then it is restrictive. If the TLC is normal or high, so some variety of other explanations are there. So what could be the other explanations? That is actually assessed by the DLCO, or diffusing capacity of lung, that is done by carbon monoxide. So if we have diagnosed that it is a case of obstruction, we will do the DLCO. If the DLCO value is less, then the obstruction is due to emphysema. If the DLCO value is normal, then it is due to chronic bronchitis or asthma. In case of restrictive lung disease, if the restriction is there, we are sure that because FVC is less, total lung capacity is less, so restriction is there. So now we will assess the DLCO. If the DLCO is less, then it is due to the interstitial lung disease probably. And if the DLCO is normal, then chest wall disorder like neuromuscular diseases, obesity may be the cause. Okay. Now one thing, if everything is normal, FEV1 FVC ratio, FVC, everything is normal, so we will say that it is a normal lung mechanics. But if we do DLCO in that patient and we see that it is low, then there may be some pulmonary vascular disease present. So this is about the algorithm. With this algorithm, we will diagnose few cases. First case is case number 1, 56-year-old young age patient, smoker, present with progressive productive cough and dyspnea for 3 months. You can see the other parameters, it is almost normal. And in the chest, diminished lung sounds you can see throughout the both lungs. The cardiac parameters are normal. In the spirometry, you can see here that the FVC predicted value, it is 61%, below 70%. So first we will see the FEV1 FVC. FEV1 FVC is less. The second parameter we will see the FVC. FVC, it is ideal value, it is 3.8, it is 2.3. It is a bit less. But what about the FE? Then we will go for the look for the total lung capacity. Total lung capacity is normal. So it is almost going in favor of obstructive lung disease. And in the flow volume loop, you can see here a coving pattern is very prominent. So it is a case of obstructive lung disease. Now come to case number 2. The case number 2 here you can see here this is the case number 1 with the chest x-ray. Now come to the case number 2, that is a 32-year-old patient who is animal trainer. So occupational hazard history is there, presents with the progressive dry cough and dyspnea over the past month. Okay, general survey, mild respiratory discomfort, and you can see the oxygen saturation level is less, and in the chest fine crackles you can hear throughout both the lungs. The cardiac parameters are normal. Now come to the spirometry value. The first measurement should be FEV1 FVC. FEV1 FVC is 94% of the predicted normal. FVC, it is reduced 39% of the predicted value. And the third parameter should be total lung capacity. Total lung capacity is also less, it is 44% of the predicted value. And if you look at the flow volume loop, the shape of the curve is normal, but you can see it is narrowed down. The gap between the total lung capacity and the residual volume, it is narrowed down. So we can say that it is a case of restrictive lung disease. And you can see the chest x-ray of this patient here. The patient is suffering from interstitial lung disease. How can we say that the patient is suffering from interstitial lung disease? Now you look at the DLCO value. DLCO value, you can see that the patient reference value is 26 and DLCO is 38. So we can say that the patient is suffering from interstitial lung disease. Now come to the case number 3. Case number 3, you can see here that a 15-year-old boy with a history of spinal cord injury. Okay, so there is a history of something other than the lung. So patient presents with the respiratory discomfort, saturation is 92%, chest is clear, and cardiovascular system is normal. So here in the spirometry, you can say first you will see the FEV1 FVC ratio more than 80%. FVC, you can say it is 70%, it is a bit reduced. Then come to the total lung capacity, it is also reduced. So it is a case of restrictive lung disease. Now look at the DLCO. DLCO, the reference value is 38 and the actual value is 37. So 97% of the predicted. So there is no change in the DLCO. So that means the patient is suffering from restrictive lung disease, and by DLCO we can say that it is not due to interstitial lung disease, it is due to something else like neuromuscular disorder. Here the spinal injury, due to this the patient cannot expand the lung properly. Now come to case number 4. A 41-year-old woman with no significant pulmonary hypertension presents with dyspnea for 2 months. General condition is comfortable, 87% of saturation. Chest is clear to auscultation. But in the cardiac parameters, you can see the regular tachycardia, there is systolic murmur, an elevated jugular venous pulse is there. And regarding the spirometric pattern, first look at the FEV1 FVC ratio, 80%. FVC ratio, it is also not bad. And what about the total lung capacity? Total lung capacity is also 98%. So all parameters are normal. Okay. And the spirometry flow volume loop is also, it is looking good. But what about the DLCO? We can say everything is normal. The DLCO, you can say the predicted value is 3024 and its value is 19. So 38% is the predicted value. So it is severely reduced. So we can say that patient is having a pulmonary vascular disease. Now case number 5. A 48-year-old man with history of smoking presents with chronic progressive dyspnea and leg swelling. You can see here. So, and generally the patient is obese, and you can see here the vitals are 87% saturation of oxygen in the chest, diminished sounds throughout the both lungs, jugular venous pulse is 12 centimeter of H2O, and there is moderate pitting edema. Patient is having some kind of pitting edema in the upper shins bilaterally. Okay. So here you can say, first see the FEV1 FVC ratio. It is 40% of the predicted value. It is less. So 37% of the predicted value. Now FVC, it is 73%. So FVC is almost normal. Now come to the total lung capacity. Total lung capacity is also less. It is 64%. Okay. And you can see the there is a coving pattern in the flow volume loop. So this is a mixed case of lung disease, both obstructive and restrictive lung disease is there, and DLCO pattern is almost 77% of the predicted value. Okay, so it is a case where there is smoking history is there, and also there is a case, it is a case of heart failure. So the both obstructive and restrictive lung disease is there. So this is the case number 5. So COPD plus restrictive lung diseases secondary to obesity, we can see here. So in a short, to summarize, we can say that first we have to assess the FEV1 FVC, then the second parameter is FVC, and third parameter is the total lung capacity. By this we can grossly categorize it whether it is obstructive or restrictive. And in case if it is obstructive, then we will do that to pinpoint the diagnosis, we will do the DLCO. If the DLCO is low, then in case of obstructive, it is emphysema. If it is normal, then it is due to some chronic bronchitis. In case of restrictive disease, if the DLCO is low, then the probable diagnosis is interstitial lung disease. If it is normal, then some other disease, chest wall deformity, neuromuscular disease, spinal cord injury, obesity, it may be the cause. Even the if all lung parameters are normal, if the DLCO is less, then pulmonary vascular disease may be present. Thank you.